Okay, it's 8:05. We will get started. I'm Dr. Noelle Spears. I'm Vice Chair for Education for the Department of Pediatrics, and we are very excited to be able to host the annual Maura Whitehead Grand Rounds Lecture. First, a little bit about Dr. Whitehead. Maura was a pediatric resident here at Children's Hospital Pittsburgh from 1984 to 1987. She was a wonderful resident, smart, dedicated, warm, and compassionate. Moira was particularly interested in the care of children with a variety of psychosocial challenges, especially children living in poverty, and was really the inspiration for the development of the CORE program here, which focuses on leadership, advocacy, and service to the underserved. After graduation, Moira served as the pediatric chief resident at Mercy Hospital, where her interest in community health and care for the underserved were continuing to develop. Moira died unexpectedly midway through her chief year, leaving her husband and young son, her parents and siblings, as well as all of us, devastated by the sudden loss of this young, spirited woman and promising physician. Moira's family, friends, and colleagues established this annual lectureship in her memory, intended to educate, stimulate, motivate the medical community to consider issues that would have reflected her sensibilities and concerns. Previous Whitehead lectures have considered the medical problems associated with poverty, aspects of public policy, and bioethical issues, among other similar topics. Although both of Moira's parents, Howard and Mary, who previously traveled yearly to Pittsburgh to honor her life, have passed away, I am sure they are here in spirit. And Peter Thorne, Moira's husband, and several of her family members are here virtually with all of us today, and welcome all of them warmly. We are so grateful to have Dr. Aparna Bole here today with us to lecture on a topic that I'm sure would be welcomed by Maura Whitehead. Dr. Aparna Bole is an associate professor of pediatrics at Case Western Reserve University School of Medicine in Cleveland. She is particularly interested in the intersection between environmental stewardship, environmental justice, and pediatric public health. She currently serves as the chair of the American Academy of the Pediatric Council on Environmental Health and Climate Change. She has served in numerous environmental health leadership roles, including as co-chair of the Health Without Harm Board of Directors, a member of the State of Ohio's Lead Advisory Council and Lead Safe Cleveland Coalition Steering Committee, the Trust for Public Land Ohio Advisory Council, and the Ohio Environmental Council Board of Directors, and the founding advisory council of the Ohio Clinicians for Climate Action. Thank you, Dr. Bole. I'll turn it over to you.
Thank you. Thank you for the introduction and for the opportunity to be with you today. I was especially really honored and moved to learn about the amazing life and legacy of Dr. Whitehead. So it's a really a privilege for me to be here, part of the tradition of honoring that legacy, which clearly is very vibrant and continues to make an impact. So thank you for the invitation. I'm happy to be here today to talk with you about really what pediatricians, what we can do to advance climate solutions as health equity solutions. I have no disclosures. And I really do want to focus on solutions today. I'm going to spend a very short time talking about the health impacts of climate change and about how climate solutions improve child health and health equity, and then really spend the bulk of the time about how we can make a difference in advancing solutions. Some of you might have heard about we've been adjusting to a number of Supreme Court decisions recently, but a recent one relevant to climate action was West Virginia versus EPA. And there's been some disappointment in the Supreme Court's decision to curtail the EPA's ability to regulate carbon emissions. But the fact is there's a lot that we can still do, and especially we in the health sector and as pediatricians. So I really want to focus on some of those solutions and opportunities for action today. I'm really proud that the American Academy of Pediatrics was the first among medical professional societies to issue a policy statement or publication calling for climate action as a public health imperative. And our climate action policy statement really describes the failure to take climate action as an act of injustice to all children. It's a pretty urgent call to action. And it probably shouldn't be surprising that pediatricians were the first to issue this call, because we're used to thinking about children in context. We think about children not as individuals in isolation, but individuals who live in the context of their family, their homes, their communities. This is something that we do every day. This is an illustration from the CDC describing the social determinants of health, which the CDC describes as the conditions in which people are born, grow, live, work, and age. Acknowledging that social determinants of health are shaped by the distribution of money, power, and resources through local communities, nations, and the world, and that differences in these conditions lead to health inequities and unfair and avoidable differences in health status. We know that as practicing pediatricians. It's something that more and more of our colleagues are going to understand. And what this really all is about place and context for patients and communities. And that is really what climate action as a vehicle for advancing health equity is all about. So I've been reflecting about place. I'm speaking to you from Cleveland, from the east side of Cleveland. Cleveland was featured a few years ago in this HBO documentary that highlighted the really shocking disparity in health outcomes, in this case, life expectancy between two physically pretty proximate neighborhoods on Cleveland's east side. We're hardly unique in illustrating that zip code can make more of a difference to health outcomes than genetic code, but this was the story that HBO chose to tell. And the two communities that were highlighted are a neighborhood called Huff, which is where my practice is located, on the near east side of Cleveland, where the life expectancy for a male baby born is 64 years, and Lyndhurst, which is a wealthy suburb about 8 miles east, where the life expectancy of a baby born is 88 years. Sticking with my theme of thinking about place, I also want to acknowledge that I'm speaking to you from the ancestral lands of the Erie people, who are the Iroquoian tribe, who originally inhabited Northeast Ohio and who continue to live, thrive, and contribute to our community today. Sort of similar to Cleveland sort of being singled out as the poster child for the story of disparities in life expectancy. Cleveland was kind of also at the center of the modern environmental movement 52 years ago now. And I sort of feel like we're in a similar pivotal moment right now, and I think we have an opportunity in our region to really lead. So just to describe what's happening in these pictures, on the left, you might recognize that picture from the Lorax. Dr. Seuss was partially inspired to write the Lorax because of how dirty the Great Lakes were at that time. There were terrible pictures of dead fish washing up on greasy shores. And this page describing the humming fish fleeing these polluted waters, the original language was something like, the humming fish are in search of water that isn't so smeary. We've heard things are just as bad up in Lake Erie. Those words were changed when Lake Erie was cleaned up, but that was the original. And then the picture on the right is sort of an infamous picture of the Cuyahoga River, which runs down Cleveland on fire. This picture was actually taken in 1952, but was run on the cover of Time magazine in 1969, and it was hardly the only river that was on fire. It wasn't even the first time that this river caught on fire, but this was the picture that really captured the national imagination. And I think these are sort of viewed as like maybe shameful parts of our history in this part of the country, but I really view it otherwise. I mean, these were really the clarion call that woke the country up to the need for a modern environmental movement. Shortly thereafter, the Clean Water Act was signed into law. In 1970, the U.S. Environmental Protection Agency was created, signed into existence by Richard Nixon. And really, we've come such a long way. And I think in a lot of ways, we're in a similarly pivotal time, a turning point right now. we know that climate change is primarily a public health issue. That's really how I describe it. And I think it's sort of suffered as a concept because of early, well-intentioned communication by environmentalists that sort of, showed imagery, the Greenpeace imagery of a starving polar bear on an ice floe, kind of connecting in people's minds that climate change is something abstract that is going to affect another species in another time and place. But really, it's affecting children and families in our own backyard. I think one aspect of being effective advocates in this space is to describe some of those really immediate effects that we're already seeing in our patients. So here in this part of the country, we see that climate change affects air quality, with surface ozone being created more in conditions of higher surface temperature. We know that ozone is good in the atmosphere, but smog on the surface can both cause and exacerbate chronic lung conditions, affect birth outcomes, and affects children's developing lungs. Extreme heat, we're seeing more frequent, more extreme heat waves in this part of the country and really all over. Heat being the most common cause of morbidity and weather-related cause of morbidity and mortality in the United States. We're seeing that here in Cleveland, seeing it affect student athletes in the fall who are coming in with heat exhaustion, experiencing football practice in really now seasonable October temperatures in the 80s, 90s even sometimes. We're seeing longer and more intense allergy seasons, especially in the northern latitudes, with earlier spring and later frost, and also with atmospheric CO2 concentrations going up. Some allergenic pollen producing plants are producing more of that allergenic pollen. We're seeing more extreme precipitation events. Oftentimes we think about storms in the southeast and around the world, but certainly extreme precipitation affects this part of the country as well, with the warmer atmosphere holding more moisture so that when we have rain events, they are more extreme, which can cause stormwater runoff that can mix with untreated sewage, overwhelming our combined stormwater and sewage drain systems, washing into the Great Lakes. In the northwest part of Ohio, we see a lot of agricultural runoff as well that rushes into Lake Erie, and that combined with the higher water temperature is sort of a perfect formula for supporting the growth of toxic algae, which is what's pictured here in the lower left, which already threatens the drinking water of many communities in my state. This is kind of a busy slide, but I think it's a helpful graphic from the last U.S. Global Change Research Program's Climate and Health Assessment, just sort of describing how climate change interacts with systemic inequities to exacerbate health inequities and to disproportionately affect the health of communities that are already vulnerable. And that's true for all the reasons sort of laid out here, that communities systematically discriminated against and marginalized, living in low-income situations might be more likely to be exposed to climate risks. They might have underlying vulnerabilities that render them more likely to have health impacts from those climate risks, and may have less sort of resilience or political or social capital to be able to adapt and overcome those impacts. So really thinking about climate solutions as providing improved health in general, but also advancing health equity, and a failure to act on climate change really exacerbating these health inequities. I'm really now going to switch to solutions and talk about those for the rest of our time. In order to do that, I just want to emphasize that there are some direct impacts, some significant direct health impacts of fossil fuel combustion on human health and on children's health specifically. Talked about air quality in the context of climate change, with rising surface temperatures increasing surface ozone concentrations. But the burning of fossil fuels itself creates air pollution that can affect a whole host of health outcomes, producing fine particulate matter, nitrogen and sulfur oxides, and heavy metal pollution. We think a lot about children with asthma, people with chronic lung disease being affected by these air pollutants, and it's true, these pollutants do cause and exacerbate chronic lung disease, including asthma exacerbations. But we know also that these pollutants affect birth outcomes. affecting increasing risk of both preterm birth and low birth weight. There was a study a few years ago in Environmental Health Perspectives that estimated the cost in the United States of preterm birth attributable to fine particulate matter exposure to about $5 billion annually. So they can have significant effects on pregnancy and birth outcomes. These pollutants also affect the developing brain. I thought that this headline was in The Guardian from a few years ago was pretty striking, describing air pollution as the new lead. We know that even prenatal exposure and exposure throughout infancy and childhood to these air pollutants can affect cognition, learning, attention, behavior, and even sleep. So, acting on climate definitely produces long-range positive health impacts, but really importantly, climate solutions are immediate child health solutions. They benefit child health right away. Accelerating our transition to a clean energy economy reduces these air pollutants, resulting in healthier birth, healthier brain development, healthier lungs, healthier kids, more sustainably designed, vibrant cities that support safe places for kids to walk, bike, and play, have accessible amenities for diverse populations of people. These immediately benefit child health, reducing air pollution, increasing social capital, increasing access to economic opportunity, providing opportunities for physical activity for children and families. More sustainable food systems and plant-forward diets also have immediate planetary and child health benefits. We know we're in this critical moment. I mentioned that I feel like we're in this sort of turning point or inflection point again. This is a report from the Intergovernmental Panel on Climate Change from a couple years ago, calling attention to the fact that we really are in a moment now. We have about a decade to act urgently to prevent climate change from sort of running away, from exceeding 1.5 degrees Celsius above pre-industrial levels, which is a point beyond which ecological, environmental, economic and health consequences become exponentially worse. And this language I've extracted just sort of underscores the fact that the IPCC also calls out climate action as an opportunity to advance health and economic justice. So what is it that we can do? It sometimes can feel like the problem is abstract, and what is it that pediatricians can really meaningfully do? The good news is there's a lot that we can do and that pediatricians are already doing. So I want to discuss that and especially call attention to some wonderful work that's happening there in Pittsburgh and in the state of Pennsylvania. Lots of opportunities to engage in your own institution. First, advocacy. Health professionals we know are highly credible messengers around climate change. Unfortunately, it's an issue that has become politicized in this country, as you know. The receptiveness of the American population to climate messaging has been studied over the years by the Yale and George Mason University groups that look at climate change communication. And they've segmented the population into these 6 groups, ranging from alarmed, like climate change is an emergency and we needed to be acting on it yesterday, to dismissive, these are climate deniers, and then everyone in between. What we know is that across all segments, primary care physicians have the highest credibility of any source on climate change information, and framing climate change as a health issue is a really effective way of reaching diverse audiences, and really summoning the political will that we need to act urgently is incredibly important. So our value as messengers should not be underestimated. Kind of in that spirit, along with the AAP, the many other medical professional societies that now have policy statements or calls to action on climate change have joined together to form the Medical Society Consortium on Climate and Health. It consists of all of these medical professional societies, ACP, ACOG, AAP, many, many others, really kind of calling the House of Medicine to speak with one voice about the urgency of climate action. There are a growing number of state climate action groups that are sort of microcosms of that National Medical Society Consortium, consisting of health professionals from a variety of disciplines who are doing this work at the state level, advocating for climate policies in their states, educating their peers and the public, and collaborating around regional efforts. So we have one in Ohio called the Ohio Clinicians for Climate Action. We work with our sister organizations in the Great Lakes around education, sharing best practices around advocacy. It's really a growing movement. And pediatricians have really been on the forefront of this work. We started, let's see, I guess maybe a year and a half ago now, a member of our council's executive committee, Lori Byron, convened this concept of AAP chapter climate advocates. So virtually all of our AAP local and state chapters now have an identified climate advocate, a pediatrician climate advocate. And this network of climate advocates has been working together on a variety of projects. I'll bring some of those up a little bit later in the talk, working together on education, on advocacy, and really amplifying pediatrician voices to call for climate action as a child health imperative. The AAP News wrote about it last year. As I said, it's almost every one of our chapters. The one chapter that does not have an advocate right now is North Dakota, but we're working on it. So 49 states, Puerto Rico, and DC, we have this really incredibly strong network. Some of what we do is writing and talking about climate policies. So I'll just show you a couple of examples. Here in Ohio, my pediatric pulmonology colleague and I have been writing about the need for clean energy investments as a child health imperative. This is an op-ed from our friends in Virginia about clean energy investments there. And this is from some of our California pediatrician climate advocates about the effects of climate change on their patients in Northern California. There are some fantastic climate advocates in Pennsylvania, based right there in Pittsburgh. So I borrowed this slide from Dr. Raghavan. They have started, Maya and Gabe have started a climate environmental health committee in the Pennsylvania chapter of the AAP, and they're doing incredible work. And I hope Maya and Gabe, if you're on, please, I invite you to add comments in the chat if there's anything else you want folks to know, but you're welcome to reach out to them to learn more. There's a lot we can do in clinical practice as well. And so I want to talk about that. Being a climate-informed pediatrician can really enhance the care that we provide for patients. This is from a recent paper from last year, kind of describing what it means to be a climate change-informed provider of primary care in pediatrics. That can include things like incorporating climate risks in screening for structural determinants of health, incorporating climate risks in anticipatory guidance and health promotion, and thinking about climate risks and climate resilience in developing the community resource network with whom we work to support patients to address their concerns and to address those structural determinants of health. Again, these are things that we already do that can be climate informed. For example, when we screen for those social determinants of health in our practice, one of the most common needs that we uncover is utility insecurity. Families who cannot pay their utility bills, we're often asked to sign those medical forms that can defer utility bills. In our practice, we've been working on coupling that intervention with connecting families with home weatherization resources in the city and county. Can be a win-win if we can partner with those local resources and agencies that can help prevent energy waste. Good for the planet, good for people, helps to prevent recurrent utility insecurity. There are movements elsewhere to do that too. I know in California, community health workers are being trained to assess homes for utility insecurity and help connect utility insecure families to home weatherization support. When we counsel families about healthy diet and exercise, talking about plant-forward diets is a win-win. It can be good for the bottom line of families who are buying food on a tight budget. It's great for health, good for the planet. We can talk about active transportation, here in our community, referring families to local safe routes to school programs to help support walking and biking to school, for example. And we can also help to connect the dots for families about climate change and clean air. We know that we're learning that parents want to hear this information from their pediatrician. I get asked sometimes, like, why do his allergies seem so much worse? Why is it so hot at football practice in October? And really talking to families about why pediatricians are concerned about climate change and clean air can be important as well. There's a lot we can do as educators in the space of climate and health. And this slide is, I know, like a lot of tiny text. I just wanted to show this snapshot from an article, another recent article about how climate and health information can be incorporated into residency education. And this just shows how these concepts can be integrated into sort of existing learning objectives and requirements of residency programs. This is another example, kind of in this article, there are some tables that show how this can be done. And this one looks at different rotations that we're doing already in our residency programs and how we can incorporate concepts and references that could be relevant to increasing knowledge about climate and health, relevant to those topic areas. There's a growing movement in medical education around climate and health. This is an example from Emory of a virtual elective that was put together during the COVID pandemic. I never want to say there's anything that's a silver lining about the COVID pandemic, but I will say that sort of advancing this model of virtual education that can be shared beyond the walls of the institution has been I think, kind of an amazing sort of growth in this area. So this is a virtual elective for M4s that included faculty from all over the country and students from all over the country. There's a growing movement among our students and residents to demand and ask for this content. The Medical Students for Sustainable Future is a group that developed something called a planetary scorecard that kind of rates medical schools' education on climate and health. And I believe there's some work in that space going on at Pittsburgh too. Some other examples of educational opportunities in this space. An MOC Part 2 module went live with the American Board of Pediatrics last year. This was developed by a group of our climate advocates. It's an example of some of the work that's come out of this network of pediatrician climate advocates that I mentioned earlier. So the MOC Part 2 module is now live, and then there will be a Part 4 module shortly. It's in development right now. I want to touch on divestment from fossil fuels too, because I think this is another important area where we as health professionals and health leaders can lean into our platform to underscore the importance of climate action and to really put our money where our mouth is. The American Medical Association is one of a growing number of organizations that has committed to divestment from fossil fuels and all of its investments. And sort of the broader concept of investing and operating incorporating so-called ESG values. So how do we incorporate our environmental, social, and governance values in the way that we as individuals and as organizations invest and run our organizations? It can be a powerful way of sort of living our values. And like I said, putting our money where our mouth is. And we've done this before in divesting from, our medical organizations have divested from tobacco, from firearms, from alcohol. So this is kind of in the same vein. It's not only the right thing to do, it's an economically wise thing to do, as really the markets are shifting towards renewable energy. Climate smart healthcare. This is sort of about how we can infuse climate action and a movement towards climate resilience in the way that we run our healthcare systems. We can have a really important role to play as healthcare leaders in this space. I want to spend some time here. This is also a growing movement. The image on the left is from a report by the World Bank and Healthcare Without Harm, describing what climate smart healthcare is. Just sort of notably, the global healthcare sector is an enormous producer of greenhouse gas emissions. And here in the United States, our health sector represents about 8.5% of the US's greenhouse gas emissions, and we are an outsized contributor to global health sector greenhouse gas emissions. The US contributes about 25% of global greenhouse gas emissions. So, talking about sort of the imperative to do no harm, like how do we mitigate that? It's a call to action, I feel like, to think about how we can decrease our own contributions to climate change. In that spirit, the National Academy of Medicine has convened an action collaborative on decarbonizing the U.S. healthcare sector. This is an article in the New England Journal from last year describing that effort. The American Academy of Pediatrics has recently joined in as a network organization. And I think it's a space where thought leadership and plans for action can really be accelerated. Just to kind of paint a picture, like how is it that health systems contribute to climate change? Well, in the way that we operate our buildings, we use a tremendous amount of energy. We have a large transportation footprint. Our supply chain, our purchasing practices have an enormous climate footprint. Our food, sort of a special category of supply chain itself, has an enormous climate footprint. And we also play a really important role in climate resilience, in making sure that healthcare delivery remains available and accessible during during times of disaster and in the context of a changing climate. Another thing I'll say is that, there's a lot that we can do to mitigate these climate impacts. But just to take a step back, really the greenest kind of healthcare is the healthcare that you don't need. And so to sort of take a step back, the bigger picture here is that investments in public health, in preventive healthcare, are inherently climate smart because they are preventing downstream resource intensive healthcare delivery. And so really, I think that fits right in with our worldview as pediatricians, that investment in prevention and in public health those are the most sustainable and greenest forms of healthcare transformation. I mentioned this sort of growing movement, just to call further attention to that. There is something called the Healthcare Climate Council, which was convened by Healthcare Without Harm, that consists of large health systems across the country really coming together collectively to make climate commitments. And they can be more powerful as a group than singularly. This is a picture of sort of the distribution of the hospitals represented in the Healthcare Climate Council, and you can see that it's very broad. So we're talking about millions of patient visits, millions of employees, billions of dollars in operating budgets represented by this Climate Council. So you can imagine that collectively, a climate commitment from this group can really change supply chains and move markets. So there's a tremendous amount of collective impact possible in this space. In that vein, recently the Department of Health and Human Services established a new Office of Climate Change and Health Equity. It was part of the Biden administration's kind of whole of government approach to climate action, and this was created by executive order last year. One of the many things that this office is charged with doing is to work with the health sector around climate action, and that's happening. There was a recent convening by the White House where I think over 60 health institutions pledged to climate action, and specifically, this is a voluntary pledge that where signees at a minimum commit to reducing their organization's emissions by 50% by 2030 and to net zero by 2050, publicly reporting on their progress, completing an inventory of Scope 3, which is supply chain emissions, developing climate resilience plans for their facilities and communities, and to designate an executive lead for this work. And in full disclosure, I actually just started a leave of absence from Case Western, and I'll be joining the Office for Climate Change and Health Equity next month. So the office is very sincere and serious about focusing on climate action in the health sector and with health sector leadership. Here's another space where there's wonderful work going on at UPMC. I borrowed these slides from, I don't want to mispronounce her last name from Dr. Isabella, describing the organization of healthcare professionals within UPMC to advance climate action there at UPMC. The email address, if you're interested, is on the page. Gabe, Maya, or Isabella, if you're on and want to add more, please do in the chat. I think that the campaign as articulated by this group is really phenomenal, and here are the goals and commitments that this group of climate leader health professionals is asking for from UPMC. And you can see that joining the Healthcare Climate Council is one of them, and joining the NAM Collaborative is also one of them. I just want to sort of broaden the scope of climate action in the health sector, kind of linking back to what I first started talking about relative to structural determinants of health and health equity. So when we think about leveraging our economic power, our political power as a health sector to advance climate action, we are talking at the same time about leveraging that power to address structural determinants of health upstream. So I'll use our health institution as an example. Our main campus is located in a neighborhood called Greater University Circle on the east side of Cleveland. These are neighborhoods that have been historically redlined and disinvested, historically Black neighborhoods on the east side of Cleveland. And so just like in many cities, we have these ivory towers, in this case, hospitals, academic institutions, and cultural institutions, right in the heart of communities that have been discriminated against, marginalized, disinvested, and have some of the worst outcomes in our city and, in fact, in the country. So it's very stark that we have these top-tier health institutions right in the middle of communities suffering from really terrible health outcomes and environmental injustice. And that's true in many cities. So several years ago, our institution, along with the Cleveland Clinic, Case Western Reserve University, the City of Cleveland, were convened by the Cleveland Foundation and something called the Greater University Circle Initiative, so-called Anchor Institution Initiative, that some of you may have heard that term. An anchor institution is a large institution, a large employer, typically a nonprofit, that is anchored in place. It's not going anywhere. We're not moving or leaving the City of Cleveland. And the idea behind an Anchor Institution Initiative is to challenge anchor institutions about how we can leverage that economic and political power that we hold to improve the health and wealth of the communities that we serve. And so in our initiative, we focused on thinking about how we can buy more locally, how can we support the local economy, so buy local, live local, how can we invest in local communities, and also encourage our employees to live locally to where they work. So buy local, live local, and hire local was the third. How can we make workforce development and sort of career entry programs available and accessible to the communities immediately surrounding our hospitals? One example of an outcome from the Greater University Circle Initiative is something called the Evergreen Cooperatives that was created by all of the anchor institutions. These are worker-owned cooperatives that are located in Greater University Circle that provide sustainable goods and services that are needed and then purchased by the anchor institutions. So one example is the Evergreen Laundry. All of the hospitals use the Evergreen Laundry for some of their laundry. This is a company that is owned by its workers. The workers specifically come from Greater University Circle, often have risks for employment, like maybe prolonged unemployment, maybe interaction with the criminal justice system. We work with a local workforce development organization to help train the workers, coach the workers, and it really creates a career development pipeline. And they also have an equity stake in the company. So this is just one example of a tangible outcome of the anchor institutions coming together to think about economic development and leveraging their own economic power in sort of a different way. This is also a growing movement in the United States and beyond of healthcare institutions thinking about themselves as anchors in their community and really leaning into that role. The Healthcare Anchor Network is the name for the group of health systems, growing group of health systems that are doing this work together, exchanging best practices. It's happening in cities around the country. I'll give you sort of another tangible example of how this kind of philosophy can play out at the intersection between clinical practice, healthcare operations, climate action, health equity. We recently built a new ambulatory center, which is the home for my practice in Cleveland. We used to be located on the first floor of the hospital at Rainbow, and now we have this new ambulatory center in the neighborhood of Huff, which I mentioned earlier. Huff was the neighborhood that was highlighted in the HBO documentary. It is a neighborhood that has been redlined, discriminated against, disinvested, the recipient of really terrible environmental injustice. There were sort of infamous race riots in Huff in the 60s that were resulted in just the neighborhood was on fire. It's been blighted over the years. This is where our new practice is located, and many of our patients come from Huff and its vicinity as well. So in planning this ambulatory center, really tried to integrate a lot of the values that I described from the Greater University Circle Initiative and from the kind of the Climate Council ethos. Our building is the only U.S. Green Building Council certified LEED Platinum building in the state of Ohio. LEED is a certification system, leadership in energy and environmental design, and Platinum is the highest designation. We have extreme energy efficiency, indoor air quality standards that were very strict, like a lot of chemicals that we avoided in our indoor fixtures and maintenance practices. We have solar panels that generate about 50% of the building's energy use, stormwater management designed into the campus. But in addition to the physical design, we convened a community advisory board that consisted of patients, families, neighborhood residents, and community organizations from a variety of sectors to think about how we could work together to advance community health and to design really the services and the physical space of the Rainbow Center together. So this is a picture from a couple of years ago of our community advisory board. So this kind of community inclusive planning was really important to this space, and also to catalyzing investments elsewhere in the neighborhood, which was important to us as well. Our community advisory board continues to meet to inform, to provide sort of a platform for community engagement, partnership, and thinking about community health, really centering community health in the broader development happening in this neighborhood, in Huff and beyond. And there's a lot of it happening. We were kind of on the leading edge of investment in this community. Just to show you some pictures, these are the solar panels. They were, by the way, installed by the Evergreen Energy Cooperative. So the worker-owned cooperative that's part of Evergreen that does renewable energy installation, installed these solar panels, which I love. These are workers from the local community who have an ownership stake in this company that installed the solar panels for us. This is Evergreen Energy Solutions. Another kind of tangible outcome from convening our community advisory board and taking this approach, we worked with a local supermarket chain in Cleveland called Dave's that was looking for a new location, and they were, I think, part of the value proposition for investing right across the street from our practice was that they were seeing that we were on the leading edge of investment in this space, and that there was a great need for supermarket access in this community. So they built a supermarket nearby, and we were able to bring our community advisory board members together with Dave's leadership to help inform the design of a teaching kitchen that we use for our patients. Our dietitians teach cooking classes, and a lot of our community partners do as well. And one of the things our community partners said was, we on our own, this is a small community organization, might not have gotten an audience with Dave's, but the fact that you all were able to convene with Dave's leadership and invite us into the room was really powerful. So I think the role that we can play as conveners is another way that we can use our political and social capital for good to amplify the voices of community in a way that can have some really tangible outcomes. This is a picture of the teaching kitchen. It's really beautiful. It can accommodate group instruction, and it's set up to sort of mimic a home kitchen, the workstations. It's not an industrial teaching kitchen at all. And if you can see through the window, there's like a little rainbow on this. I don't know if you can see my arrow, but that's our practice right across the street. That's the Rainbow Center. This is just an example of some of the cooking classes that we have every month that are free for our patients. I think I'll conclude by sort of going back to where I started in thinking about place and the power of place and how we can influence the place where our patients live. I started out by talking about the pollution in Lake Erie and Cuyahoga River on fire, and how that really energized and inspired the modern environmental movement. I just want to show you what those places look like now. Some of you might be familiar with Cleveland, but if you're not, the picture on the left is Edgewater Park, which is one of the most beautiful assets of our city, this beautiful beach. The right two pictures are from the Cuyahoga Valley National Park, whose biodiversity and beauty really are a testament to how far the environmental movement has really come. It just kind of reminds me that we can do hard things. We've done it before, we've been here before, and I think we're in this pivotal moment as we think about addressing big problems: climate change, health equity, racial injustice. I think sometimes we think about those as being separate problems, but I think they're all ways of describing sort of the same problem. The COVID pandemic, I think, really underscored the inherent vulnerabilities of our social and economic systems that rely on extraction, exploitation, consumption, and disposal. We can see that, as economic and health inequities have been exacerbated during this time of the pandemic, I think we can see how vulnerable those systems are. So I think we have a real opportunity to think transformatively about rebuilding and recovery in a way that really integrates more sustainable, regenerative, and just economic and social systems, that integrates climate action, health equity, and a true care for protecting the health of children. I really believe we can do it. This is an example of how we can do hard things. And I know that pediatricians can and already are playing such a critical role in advancing climate solutions. Now is really our moment. I just want to acknowledge colleagues who contributed to this presentation, and these are some of the resources that I mentioned in my remarks. As I mentioned, I am transitioning to being part of the Office for Climate Change and Health Equity at HHS, so I put my personal email address on here. I welcome your questions after the fact, or I think we have a few minutes now if folks have questions or comments. This is a picture of my then kindergartner at the Cleveland climate strike a few years ago. She was on strike from kindergarten. Thank you so much for your attention, and I'll look forward to questions.
Thank you, Dr. Bole. That was outstanding. What a powerful talk, and all of the actionable, suggestions for us based on your experience and expertise were incredible. So, so grateful for you to give us this presentation today. Peter Thorne, Dr. Thorne does have a question for you. He says, thank you, Dr. Bowles, for a great talk. I teach public health undergrads in a course called Climageddon, Climate Change and Health. Increasingly, my students are experiencing climate anxiety and feel overwhelmed with fears of a disastrous future. Many speak of not having children because of climate change. Are pediatricians watching for climate anxiety and climate depression in their practice?
Thank you for that question. As you know, Dr. Thorne, that's a growing area of concern for psychologists and psychiatrists. The APA is focused on this issue. I think there is an increasing understanding of how this might be affecting our patients among pediatricians. We recorded a podcast last year for AAP on Radio MD about how to talk to children about climate change and how to keep information truthful but yet hopeful and action-oriented, which I think is a way of getting at this issue of climate anxiety. I also had a recent experience. I've been working more with youth climate advocates and activists, which parenthetically is an incredibly potent way of combating this issue of climate anxiety, just experiencing how effective these youth leaders are. And one of them was talking to me about how she brought this issue up with her healthcare provider, that she was having this sense of doom and anxiety. And she was saying, it's not, she was really insightful. She was saying, it's not like anxiety where I'm having a pathological response to a stimulus that is like relatively small compared to my response, right? This is like it's rational to have some anxiety and fear, and I felt like my doctor didn't really know how to talk to me about that. It was a different kind of anxiety. So I thought that was really insightful, and she was joining me in educating some adolescent medicine providers here in in our region. All of which is to say, I think that our youth climate advocates have a lot to teach us. I think it's a different way that we talk to patients and children about legitimate fears and anxieties that needs to be honest, hopeful, and action oriented, and not pathologize it. So I think it's a difficult and thorny issue, but I think it's increasingly, to answer your question, increasingly becoming something that pediatricians are understanding. Actually, in this year's AAP's NCE, there's going to be a whole session about climate anxiety that we're putting on with the section on developmental pediatrics and adolescent medicine. So it's very timely, your question.
Yeah, fabulous. Thank you.
I will also thank you as well for shouting out to Dr. Raghavan. And if if folks didn't notice her email in the chat to reach out to her and Gabe, and I'm sure Isabella would also welcome any faculty or trainees that are interested in getting involved locally here. I was particularly struck by the Evergreen Cooperative. I mean, what a incredible, resourceful opportunity for the community. How were you involved on the front end of that? And if so, establishing, something similar, what do you think the first steps would be?
Well, yeah, I was. And the Evergreen Cooperatives, I will say one really transformative thing about our Anchor Institution initiative in Cleveland was that we have a very, very strong community foundation in the Cleveland Foundation who convened us. So, and they also helped to fund things like launching the Evergreen Cooperatives, which it took some funding to get off the ground. And so do the Anchor Institutions, though. But you have really strong local foundations in Pittsburgh too, so it's not so different. I will say that I think an important first step, even before the Evergreen Cooperatives were imagined, was to think about our role in workforce pipelines in general in our own institutions. Like what we found when we kind of surveyed our practices in our own institutions was that it was really, really difficult for local community members to access jobs. The way that we posted jobs online, the number of applicants per position was enormous. The automatic filtration processes oftentimes like excluded people, who maybe had like a prolonged period of unemployment or different sort of barriers to employment that should not be insurmountable, but would sort of automatically filter a lot of individuals in our local community, either because they couldn't view the posting, they couldn't submit their information in the way we were asking them to online, or the automatic filters would just filter them out because we'd get like thousands of applicants for each position. So I think the really important starting point, like even before the Evergreen Cooperatives were conceived, was to challenge ourselves to change the way that we looked for new employees and thought about career development including in frontline roles like nutrition services and environmental services. So designing our own workforce pipeline was a huge culture change to begin with. Like actually going out into the community and greater university circle to invite applicants in person and to see value in increasing the number of employees who come from those local neighborhoods, partnering with Towards Employment, who's our wonderful local workforce development organization, to find those individuals and also to help train and coach those individuals while they were coming on board, because there's also a lot of turnover in some of those roles, and so it was mutually beneficial to do that. So I think that it was really transformative to rethink the way that we do our hiring and attract and retain and develop employees who come from greater university circle who may have some employment risks that we need to work together with them and towards employment to overcome. So I think once that happened, like then there was more of an openness to like thinking about leaning into something like Evergreen Cooperatives, and that's kind of how the journey started.
That makes a lot of sense. Dr. Dermody has a question along our chair, the same line. He says, Dr. Bole, thanks for a great talk. Would you say a few more words about the teaching kitchen? Are you studying outcomes in any way? How is it funded? Thank you.
Yeah, and I will tell you, I'm not directly involved with the teaching kitchen now and have not been for a while. So I cannot speak as much to like what's happening with research around outcomes. I know that there have been folks in our department interested in that, and I can't speak to it. So I apologize for that, but I can tell you how it started and how it was funded. again, like we're lucky we had this local supermarket chain that specifically opens markets in Cleveland. It's really committed to, Dave's is a family business that is committed to Cleveland specifically, and they were open to meeting with community members. So they were open to the conversation, and then we secured some funding from the Department of Health and Human Services to help support the construction of the kitchen. And then now there is some ongoing funding plan that comes from, like, if a corporate entity uses the kitchen, they pay to use it. But then if a local nonprofit uses the kitchen, they do not. So that kind of helps sustain. But there is some investment from Dave's. There's some ongoing investment from corporate partners who use it for events or for cooking classes and things like that.
Thank you. I don't see any other questions in the chat, so we'll be able to move over to the meet and greet. There's a separate link for that. Folks can join us and meet Dr. Bole and ask additional questions. I'll just end with Dr. Arslanian, the picture there. And I think that's the heart of things, right? In teaching and education, and decreasing the anxiety of the next generation and getting them involved. So what a great representation of that. Thank you so much.
Thank you for the opportunity. It's really been a pleasure. Appreciate everyone's attention.